Fluid loss management. Fluid replacement therapy in burns. 10 marks. Fluid loss after a burn. Fluid shifts from vascular to interstitial and intracellular spaces because of increased capillary pressure, increased capillary and venular permeability, decreased interstitial hydrostatic pressure, chemical inflammatory mediators, and increased interstitial protein retention. This is compounded by evaporative water loss from a disruption of the skin. In burns of more than 20% TBSA, this fluid shift becomes massive and requires immediate fluid repletion. This fluid shift, referred to as burn shock, is a life-threatening condition because of hypovolemia and the potential for shock-induced renal failure. History. Mechanism of injury. Time of injury. Surroundings, closed space or chemicals. Physical examination. Head-to-toe assessment. Careful neurological examination for cerebral anoxia. Pulmonary assessment. Pulse in extremities. Manual or Doppler. Loss of distal circulation. Pallor, coolness, absent pulse, loss capillary refill, decreased oxygen saturation. Absent pulse. Emergency sclerotomy to release constructive, under-yielding scar. Sclerotomy. It is the surgical division of the non-viable skin and tissues, which allows the labs CBC, electrolytes, BUN, ABG, chest X-ray, carboxyhemoglobin. Monitor cardiovascular status, which includes blood pressure, electrocardiogram, heart rate, renal status, urine output 30 to 50 milliliters per hour, 1 gram equals 1 milliliter. The desirable amount of fluid intake and loss in adults ranges from 1500 to 3500 milliliters each 24 hours, average equals 2500 milliliters. Normally intake equals output. Assess oral fluids. Assess tube feedings. Assess parenteral feedings. Assess intravenous medications. Assess catheter. Assess vomitus or liquid feces. Assess diaphoresis. Assess tube drainage. Assess wound dressing or wound fistula. Assess postural hypertension is common for postural persons with fluid volume deficiency. Phases of management of burn. 1. Emergent phase. Resuscitative phase begins at the time of injury, the time duration between 24-48 hours. This phase is characterized by life-threatening airway problems, cardiopulmonary instability, hypovolemia management. The primary goal at this stage is to prevent hypovolemia causing edema, shock, maintain vital organ function and perfusion. Assess airway, breathing, circulation, endotracheal tube intubation along with assisted ventilation with 100% oxygen. Indications for intubation: O pharyngeal erythema, O swelling on direct visualization, O change of voice, O harsh cough, O stridor, O dyspnea, O tachypnea. For circulation: 1. Secure intravenous line. Large bore intravenous catheter should be inserted. Secure I.V line, peripherally inserted central catheter. Most patients have a central venous catheter inserted, so that large amount of fluids can be given quickly. Or secure intravenous line, peripherally inserted central catheter, central venous line, venous cut, venesection, down, whichever is convenient as for the patient. Oral is preferred. Nutritional therapy 2. Plus high protein and high calorie diet, otherwise, nasogastric tube is necessary. People with extensive burns or who are undernourished may need nutritional support. Eternal gut is preferred alternative route. G-tube or J-tube, head injury, surgery, unconsciousness. Parenteral total parenteral nutrition or PPN, parenteral therapy. Fluid replacement therapy. The total volume and rate of fluid replacement are gauged by the patient response and guided by the resuscitation formula. 3. The adequacy of fluid resuscitation is determined by monitoring urine total output. 4. Urine output totals of 30 to 50 milliliters per hour have been used as the resuscitation goal. 5. Other indications of the adequate fluid replacement are a systolic blood pressure exceeding 100 mmHg and pulse rate less than 110 beats per minute. Parkland formula is a suitable starting guide. intravenous route administration of fluids and electrolytes directly into the bloodstream using continuous infusion blusin or intravenous push injection through peripheral or central venous site Foley's catheter tetanus prophylaxis -2. Weight of the patient daily weights 1 kg equals 1 liter of fluid. Daily weighing is also useful to monitor fluid and electrolyte balance. 3. Estimation of size of burn. Classification of burn by surface area. Total body surface area TBSA can be calculated in percentage by following methods. Rule of 9. Wallace's Rule of 9. It is useful for immediate appraisal of the burned area. This assigns percent in multiples of 9 to measure body surface. Body is divided into areas, each represents 9% of all multiples of 9. Middle. Palm method. In patient with scattered burns, the size of patient palm is approximately 1% of TBSA. It serves as a general measurement for all the age groups. Protect the area from contamination. 4. Start resuscitation. The adequacy of fluid resuscitation is determined by output totals of 30 to 50 ml per hour, systolic blood pressure exceeding 100 mmHg, pulse rate less than 110 per minute. 5. Maintain sterile barriers. 6. Vital signs, tachycardia, first sign of hypovolemia. Various formulas. 1. Consensus formula: lactate ringer solution, or other balanced saline 2 4 ml x kg body weight x% TBSA burned, half to be given in first 8 hours, half to be given over next 16 hours. 2. Evans formula: colloids equals 1 ml x kg body weight x% TBSA burned, electrolyte equals 1 ml x body weight x%. BBSA burned glucose 5% in water equals 2000 ml for insensible lost. A1, half to be given in the first 8 hours, remaining half to be given over next 16 hours. Day 2, half of previous day's colloids and electrolyte cells of insensible fluid replacement. 3. Brooke-Army formula: colloid 0.5 ml x kg body weight x% TBSA burned, electrolyte ringer lactate 1.5 ml x kg body weight x% TBSA burned, glucose -2000 ml. 4. Parkland formula: lactate RL -4 ml x kg body weight x% TBSA burned. Day 1, half to be given in first 8 hours, half to be given over next 16 hours. D5LR. Day 2, various colloid is added. The projected fluid requirement for the first 24 hours are calculated based on the extent of the burn injury. Some combination of fluid categories may be used, including colloids and crystalloids. Generally, of crystalloid solution is ringer lactate solution. Adequate fluid resuscitation. Intravenous fluid therapy results in slightly decreased blood volume level during the first 24-hour post-burn and restoration of plasma level to normal by the end of 48 hours. Plasma, sodium-rich solutions, and other fluids are infused according to a formula derived from individual TBSA and body weight. The specific formula used varies according to hospital preference. During and after fluid administration, the patient is monitored closely for adequacy of fluid resuscitation. Heart rate, blood pressure, cardiac output, base deficit, urine output, and bowel sounds provide valuable information about the effectiveness of fluid resuscitation, as do peripheral body temperature, capillary refill, and mental status. 1 liter of water equals 1 kilo of water by weight. Fluid replacement are calculated according to this ratio plus 1.5 to fulfill the current daily needs. Oral supplementation may start 48 hours after 48 hours after, as homogenized milk or soy-based products given by bolus for constant infusion via NGT. Albumin 5% may be used to maintain serum albumin levels at 2 gram per day. PACT-RBC recommended. If hematocrit falls below 24%, hemoglobin level less than 8 gram per dl, sodium supplementation may be needed. If burns greater than 20% BSA. Advantages of fluid replacement therapy. Middle. Provides the patient with life-sustaining fluids, Electrolytes and drugs. Immediate and predictable therapeutic effects. Preferred for administering fluids, electrolytes and drugs in emergency situations. Allows fluid intake when a patient has gastrointestinal tract malabsorption. Permits accurate dosage titration for analgesics and other drugs. Fluid replacement therapy administration routes. Oral route. Oral ingestion of fluids and electrolytes as liquids or solids administered directly into the GI tract. Nasogastric route. Installation of fluids and electrolytes through feeding tubes, such as NG, gastrostomy and jejunostomy tube. Resuscitation solutions. Colloids like albumin, dextran, heterstarch crystalloids like ringolactate, D5%. Hypotonic saline. Defense of ringolactate used are normal saline ringolactate plasma Hartmann fluid. Ringolactate is the fluid of choice. It is preferred solution at least in the first 24 to 48 hours because it is isotonic crystalloid. It has low sodium concentration as compared to normal saline. It is 130 mg. Liter has higher pH, hence near to physiologic pH, has a buffering effect of the metabolized lactate on the associated metabolic acidosis. It is free of glucose converted to bicarbonate. Most psychological blood is transfused in late period after 48 hours. When does resuscitation complete? When no more accumulation of edema fluid, 18 to 30 hours was post-burn, or resuscitation fluid required till volume required to maintain urine output at 30 to 50 milliliters per hour equals maintenance volume. Disadvantages. Solution incompatibility. Adverse reactions. Infection. Nutritional therapy. High protein and high calorie diet. To acute phase. Wound healing phase begins when patient is hemodynamically stable, capillary permeability is restored, and diuresis has begun 48-72 hours after the time of injury. Deep second and third degree circumferential burns. Chest to allow respiratory movements. Limb to restore circulation in the limb with excess sweating under rigid scar. Not in subcutaneous tissue. Expose subcutaneous fat. Management. The goal at this stage is to prevent infection, provide metabolic support, wound care, wound cleaning and restorative therapy continuous until wound closes. 3. Rehabilitative phase. Restorative phase. Recovery represents the final care of burn injury, overlaps acute phase and extends beyond hospitalization management. The goals are designed for maximal function and emotional recovery, such as wound healing, increase physical health and function, provide emotional support, protect the area from contamination over resuscitation. Fluid creep. Skin edema. Compartment syndrome. Pulmonary and cerebral edema. ARDS. Increased cost and mortality. Avoiding the creep. Avoid early over resuscitation. Early institution of colloid rescue. Changing resuscitation protocols. Causes of failure of resuscitation. Extreme major extensive burns. Major electrical injury. Major inhalation injury. Initial delay in initializing fluid. Underlying disease that limits metabolic for cardiac reserve. Innovations. Burn fluid resuscitation calculator. A dedicated calculator for determining correct burns fluid resuscitation, which improves speed. Reduce human error. When does resuscitation complete? When no more accumulation of edema fluid. 18 to 30 hours post-burn. Resuscitation fluid required till volume required to maintain urine output at 30 to 50 milliliters equals maintenance volume. Diagnostic evaluation. For evaluating fluid status. Osmolarity measures the solute concentration per kilogram in blood and urine. Osmolarity concentration of solution per liter BUN, 10 to 20 mg per dl, made up of urea, an end product of protein metabolism by the liver. Serum electrolytes. Complete blood count. Abnormal chest X-ray which indicates fluid accumulation. Main reveal pulmonary edema or pleural effusion. Laboratory results should be reviewed for various fluid and electrolyte disturbances so that appropriate adjustments to therapy can be initiated. Nursing diagnosis: O fluid volume deficit. O high risk for fluid volume deficit. O altered oral mucous membrane. O wound care. O prevent from infection. O pain minimization. O acute anxiety. O dehydration. O local tissue edema. O risk for hypovolemic shock. O prevent aspiration. O prevent tetanus.